Hello, everyone. My name is Grayson Armstrong, and I'm a comprehensive ophthalmologist at Massachusetts Eye and Ear, and I'm an instructor in ophthalmology at Harvard Medical School. Today, we're going to talk about hybrid telemedicine. I have two conflicts of interest to disclose. First, that I'm a co-founder of a company called Ocular Technologies, and second, that I consult for Korea Therapeutics. Telemedicine in ophthalmology is predicated on the idea that a patient and a doctor can communicate via virtual means. In order for this to work in ophthalmology, we generally need to be able to evaluate the eye, interpret the images of the eye to make a diagnostic decision, and then use virtual means to relay that plan back to the patient. Today, we're going to talk primarily about capturing the images and interpreting the images. All of this together stands to improve access to care and patient satisfaction, decrease healthcare costs and health disparities, and ultimately maintain or even improve healthcare quality. So there are many models of telemedicine. The first of which is synchronous telemedicine, which is where you use something just like Zoom or Skype to communicate with the patient in real time. Asynchronous telemedicine is where an image or report is sent to an ophthalmologist for review. They interpret this asynchronously and send the report back to the patient or to the primary care doctor. There's also remote patient monitoring, where devices are used to monitor a patient in real time, sometimes in the home, and those results are sent to the ophthalmologist in real time for review. But hybrid telemedicine is unique in that it draws on all of these aspects of care to provide more clinical information to the ophthalmologist. In a hybrid telemedicine setup, a patient comes into the office for a testing-only visit. During this visit, you can check their visual acuity of their manifest refraction, their eye pressure and OCT, slit lamp imaging. You can even obtain retinal imaging or visual field testing or otherwise. All of this is then sent to the ophthalmologist for interpretation asynchronously. And subsequently, when this is all done, the patient and the doctor can hop on a synchronous video call. The screen can be shared to show the results, and the ophthalmologist can make a treatment plan with the patient. So how does this work in terms of a workflow? Well, first, the ophthalmologist, knowing the patient, can order the testing that's appropriate. The patient can then schedule the testing at a time and location that's most convenient for them. The patient goes in person for their testing and subsequently goes home. The imaging is relayed to the doctor for interpretation and review, and a virtual visit is subsequently performed where the doctor and the patient review the images together. An assessment and plan is created with the help of the patient on the other side, and ultimately billing and coding is performed for reimbursement. All in all, the patient and the doctor should walk away happy knowing that they had enough clinical information to make an informed treatment plan. This is especially useful in ophthalmology because we have such an exam-heavy specialty. And so what kind of exam techniques and images and testing can we perform? Well, in terms of subjective examination, we can check visual acuity. The technician, when they come in, can check the visual acuity for you. And they can also do a manifest refraction, or if that's not possible, they can at least obtain an autorefraction. The technician can check their color vision or Amsler testing or any other subjective testing that's worthwhile. In terms of objective testing, you can check the pupils and anterior segment imaging. You can check intraocular pressure, either via Goldmann testing or non-contact testing, whichever is appropriate for your clinical setting. You can obtain posterior segment imaging or other ancillary testing like a visual field. In terms of patient selection, some diseases are really amenable to this. The first of which is glaucoma. Now, glaucoma, as you know, is very testing heavy, and the practitioner generally uses a lot of testing information to inform their clinical decision making. And so, if you can get all this testing asynchronously, then the physician should be able to make an informed treatment plan with the patient via telemedicine. And the same is true for AMD, where you can evaluate people via fundus photos and OCT of the retina. But ultimately, any patient whose exam can be captured remotely, and any diagnostic imaging that can be performed can be used for this model of care. The benefits for this are multifold. First, this can improve patient access. And so you can put the testing in the local communities where the patients are, which decreases the need for travel or time off of work. Second, the ophthalmologist obtains better clinical information that goes well beyond what can be captured via Zoom or Skype, like you and me talking right now. Third, this can help tackle health disparities. Many patients will lack smartphones, computers, or broadband access, and that limits the ability for video visits to take place. And lastly, it can help reduce disparities in communication. As you know, in ophthalmology, many patients will be low of vision or hard of hearing, and this can make the video visits or audio visits especially difficult, and this capturing the testing ahead of time can be beneficial for the ophthalmologist. Billing for hybrid telemedicine is very much like billing for any other visit. You would use E&M codes to bill for time-based, medical decision-making based, or I-code-based billing. You then would apply the appropriate modifiers in place of service and bill for the imaging and testing. But the piece that's unique for hybrid telemedicine is that because you're obtaining better quality testing and imaging and have more clinical information at your fingertips, it makes for a stronger argument to bill via medical decision making. And lastly, you can bill for every single image or test that's performed. This is a really quick overview of hybrid telemedicine. If you have any other questions or concerns, please do not hesitate to reach out to me. I'm happy to answer any questions. Again, my name is Grayson Armstrong at the Mass Eye and Ear, and I'm more than happy to touch base with you later. Thank you.